to call out if I see things in the chat, or do you want to take pauses to?
I'll probably take pauses, but if there are things that are really that are pertinent to a specific slide, feel free to call it out too, Lindsay.
Okay, sounds good.
But there will be pauses, yeah.
Okay, we'll give folks another minute to come back. I'm gonna throw just a little bit of oat milk in my tea. Okay, we're at 9:55. Gina, do you want to go ahead and get started? I think folks are coming back. If you're coming back, go ahead, turn on your camera if you can, so we know you're there, and we'll turn it over to Gina.
All right, thanks, Lindsay. Hi, everyone. My name is Gina. I've met many of you. I am an R2 in the primary care track, and I am going to be talking to you guys about treating chronic pain as a PCP. So I also have no financial disclosures, and I will say my caveat to Lily's prior point is that I chose this talk not because I love it, but because I actually really struggle with it and I wanted to learn more about it. And I think if there's anything that I learned, it's that there's no one way to treat chronic pain, and it's a really big topic. So I would love for others to chime in if they have any good tips for treating their patients, particularly in your clinic context, which might be different than my clinic. Then I want to talk through the objectives of the talk, which are to define chronic pain and identify populations who may be more at risk for developing chronic pain, to develop an approach for educating your patients and to really make it your own, to describe non-pharmacologic modalities for treating chronic pain, and then to talk more about a medication prescribing strategy. So the entirety of the talk is going to surround one case, and this will be a little bit of a choose your own adventure. So I'm going to have people vote on what they want to do in the case, and that'll sort of dictate where we go with the talk. And so be ready to participate with your Zoom polls. So getting into the case, this is about Betsy. She is an 84-year-old female, the history of hypertension, 2 prior TIAs, who presents to you for a new patient visit. It's July 1st of your intern year. You are talking with her, and she tells you that she left her prior PCP because she didn't feel like she was being listened to. She has a whole lot to say, and you have done an absolutely tragic job of agenda setting. She tells you that she wakes up every morning with pain, and so you ask her more about it. You find out that she's got this bothersome pain in her legs that's not positional, but feels like it gets better with walking. She's got pain in her knees that's exacerbated by gardening. And then she's got lower back pain and pain in the mornings that feels like it's all over. All this pain has been worsening over the last few years. Her only medications are clopidogrel and atenolol, and she doesn't take any medications for the pain. She has been going to PT though for about 6 months, and she loves her physical therapist, Jeff, but feels like it has helped pretty minimally. All right, what would you like to do next? Would you like to suggest a trial of either gabapentin or duloxetine, prescribe acetaminophen, order an x-ray of her knees, discuss a referral to acupuncture, or wow, you are just overwhelmed, let's not do anything today, and we'll have her come back in a few weeks? Go ahead and put your votes in. Are you guys seeing a Zoom poll? There we go, perfect. Oh.
Sorry, Gina, let me, I think I have to relaunch the poll.
No worries.
There we go.
Awesome.
Should be seeing it now. Okay, great. I was busy thinking about what I wanted to do.
I love it, Anna. There's never a right answer, right? Okay, maybe we'll give it a couple more seconds and then we'll see what people want to do.
Yeah, I still see some responses trickling in. We'll maybe give, we'll say 10 more seconds. All right, go ahead and end the poll.
Okay, so, all right, we have a tie between the first two. They actually have very similar answer choices in our, of where we go from here. So I'll go ahead and click, let's say, for A. All right, so you go to staff with your attending, and then you go back into the room and explain that there are some great medications, gabapentin and duloxetine, and we'll throw Tylenol in there too. She actually tells you that she wants to avoid medication altogether, and she wonders if her clopidogrel is actually making her feel this way. And she wonders if she could actually discontinue that because maybe that's causing the pain. You are now overwhelmed, and you realize you have probably a lot more to talk about with Betsy, so you have her schedule a long follow-up in 2 weeks. Taking a step back from the case, what exactly is chronic pain? So very technically, chronic pain is defined by the International Association for the Study of Pain as pain on most or every day in the past 6 months. And then in 2010, there was this push by the NIH and the Institute of Medicine to create this national pain strategy. And one objective of that was to really quantify the burden of chronic pain in our society in the US. And this was sent through a large household survey, and they found that 20% of US adults actually had chronic pain. And 8% of those individuals had high impact chronic pain, or essentially chronic pain that leads to disability. Also, through this National Pain Strategy Survey, they identified vulnerable populations or patients that may be more at risk for developing chronic pain. And they found that chronic pain is more common in women, older adults, and rural residents, as well as those who are from lower socioeconomic backgrounds or those living in poverty, and those with public health insurance. Not specifically mentioned in the NPS, but several populations also known to be at risk for chronic pain are those who have experienced childhood trauma, or ACEs, or adverse childhood experiences. Those with adverse childhood experiences have been shown to have a 2 to 3-fold increase in the development of chronic pain later in life. And then in addition to that, patients with past trauma in general, and I'll call it our veteran population here, are also at risk for chronic pain. 15 to 35% of patients with chronic pain also have PTSD. So I think these two last points really speak to the importance of taking a really good social history and employing trauma-informed care with our patients with chronic pain. And then finally, I do want to point out that race is a very complex variable when it comes to chronic pain, and studies have shown slightly different verdicts on race and its relationship to chronic pain. In many studies, when controlling for some of these other variables like socioeconomic status, public health insurance, education, et cetera, they find that race is not associated with chronic pain. That said, given what we know about structural racism, and it's important to sort of reflect how our patients' race might impact their trajectory of their life and some of these other variables that I already talked about, and when we're treating patients with chronic pain. Coming back to our case then, you bring Betsy back for a 40-minute appointment, and while you're pre-charting, you look through and see that she's actually got all this prior imaging on Care Everywhere in the last 2 years. She has had an X-ray of her knees, a lumbar spine MRI, and ABIs, all of which were normal, except for some mild osteoarthritis in her knees. You do a better job of setting your agenda for the visit, and you say that you want to spend the entire appointment talking about her pain. Go ahead and put in the chat what are some key things you want to do in this appointment. Listen. Oh, I love it, Anna. Cool. Many votes for listen. And we'll certainly get back to listening to Betsy. Any other things that anybody wants to say in this first appointment? Understand how pain is impacting your functions. Awesome. Get a sense of other things she's tried. Perfect. How you can help her. So more patient-centered things, which I love. Okay. So I am not going to sort of belabor the history and physical portion, and we'll get back to sort of hearing more about Betsy's story. But you guys hit on a lot of really important topics there. Another thing that you do sort of want to focus on is sort of what have they been treated for this pain, and then sort of be thinking about some semblance of diagnosis of whether you do need to do more workup, and what workup has been done in the past. And then I see in the chart, Anna, setting expectations, and we will get to that. The next thing I do want to focus on is talking about how you do educate patients on chronic pain. And so much research out there has discussed patient education and how it's this cornerstone of chronic pain management. This is not something I was doing with a lot of my patients with chronic pain, but it's really important to help them reframe their pain and work on self-management. So here's a framework that you might employ to educate your patient on their chronic pain, but I encourage you to also make this your own. The first 2 points may be a little bit more self-explanatory. I would encourage you to start by assessing your patient's understanding of what is going on. And I think that's what a couple of you guys mentioned in the chat. And then acknowledging what they've been through, whether that's what they've been through in their life and prior trauma, or their experience in the healthcare field, as you are probably not the first doctor they've seen for this, or you may not be. The next 3 points, though, are maybe even more important to touch on. And they are, number one, reducing normal fears, reducing very normal fears that something bad, something wrong is going on if you're feeling pain. Fear can actually be a really big contributor to ongoing chronic pain. So making it clear to your patient that we now know a lot more about chronic pain, and we understand that pain doesn't always mean that something is wrong, something is hurt, something is injured. And it may be better to frame chronic pain as a chronic disease like diabetes or hypertension, rather than a symptom of something else going on. Which leads to the fourth box of explaining this biopsychosocial model of pain. So over the last 50 years or so, there's been a lot more research and data on chronic pain. And what we have learned is that pain is complex. Research has shown that pain is mediated by so many things outside of a physical biologic injury. And it's related to things like past experiences, trauma, mental health, physical activity, lifestyle, diet, and so much more. And so this concept is important for how we're going to treat and address pain too. And then Anna brought up this setting expectations. This is really huge. As you transition to sort of talking about treatment of chronic pain, set very clear expectations that you probably won't be able to totally eliminate their pain completely. Research actually shows that a 30% reduction in pain is pretty typical. That said, you do want to empower them as well. And I think Anna mentioned this. Empower them by telling them that even small reductions in pain lead to better quality of life and improved function. And I encourage you to sort of make your goals around increasing their function, as Lindsay had mentioned, rather than on truly decreasing their pain number. And the purpose of this graphic here is not for you to read everything on it, but rather to point out why pain is so complex. You can see how many regions of the brain impact the way we perceive pain signals, encode them, integrate them, modulate them. And this is why treating pain is so challenging. You might even show this to your patients. And this is why research now has embraced this biopsychosocial model, and why not a single pill or therapy can make your pain disappear. Now, I understand that sort of in a clinic visit, some of these things you say to the patient might not stick the first time around. So there's actually some really good resources out there. There are some what are called layperson self-management programs to help patients understand chronic pain a little bit better. I don't know if anybody's familiar with this one, but this is one resource. It's called tamethebeast.org. There's a really wonderful short video that on the website that talks about the complexity of pain and the biopsychosocial model. So this might be something you share with your patients or look into yourself if you're more interested. Then getting back to our initial visit, something you might also think about is how you might measure or track pain. This is actually not something that I have tried, but it's shown that it might be helpful in tracking really small changes over time. This tool is a validated tool published in JGIM in 2009. It's called the PEG tool. And you can see here that, yes, there is a pain score, but the two other values that you might be asking your patient about are how their pain is impacting their enjoyment in life and their activity. So this is where you can really start to make more functional goals with them rather than just focusing on their pain number. And then last but not least, in many guidelines and studies, frequent follow-up is emphasized, both to track the progress of the treatments and to continue education and to allow your patient really to build trust in you. A good therapeutic relationship is really important in chronic pain treatment. So if you didn't get anything out of this topic, I hope that you understand these key points. One, that education is a critical first step of chronic pain treatment before you even start talking about the therapies that you might employ. I would encourage you to schedule a separate appointment to educate your patients because it may take some time. And even if you've had a patient that has chronic pain and you've seen them many times, it's never too late to tell them that you want to schedule a separate appointment to talk specifically about their pain and do some more education. Then I want you to emphasize the biopsychosocial model of pain, and there are ways to do that outside of a clinic appointment with some self-management tools. And then really emphasize building trust in your relationship and really understanding your patient's story. I'm going to pause here for any other questions. I see in the chat, Natalia, is there any role for low-dose naltrexone for the management of chronic pain? I did not see that, Natalia, anywhere in my research. And we'll get a little bit more to the medication. Naltrexone didn't come up in any sort of the papers that I studied, but there may be something out there. So interested to hear if anybody else has any feedback on that. Any other questions? Amazing, thanks, John. Okay, moving on to our next section. So coming back to our case, you listened to Betsy's experience of her pain and you asked her more about her life. She tells you she's originally from Eastern Europe and she fled her hometown during World War II. She lived as a refugee for many years. As a young adult, she and her two sisters, who have now both passed away, came to the US. She had been living in Paradise, California until about 3 years ago when the campfire burned down her entire home and all of her possessions in Paradise. She has no partner or children, so she moved to Seattle to live with her niece. She tells you she doesn't know what the pain is from. You take time to review all of this imaging findings on Care Everywhere, and you reassure her that there are no scary findings. You tell her about chronic pain and this biopsychosocial model. And she always wondered if some of this pain was emotional pain. You do a PHQ-9, and her PHQ-9 is 25. And here's actually a picture of the fire in Paradise, California. And Betsy has brought in pictures of her home that look very similar to this. Okay, another Zoom poll here. What do you do now? Suggest a trial of pregabalin, prescribe acetaminophen, discuss referral to behavioral health, discuss referral to acupuncture, or both A and C.
It looks like we still have a few answers coming in. We'll give maybe about 10 more seconds. All right, I'm going to go ahead and end the poll here.
All right, E, overwhelmingly E. And so you acknowledge how much Betsy has been through in her life, and you thank her for sharing all of this with you. You discuss that in addition to chronic pain, you think she's also suffering from depression, and oftentimes the two can be linked. You discuss both medication and therapy options for treating depression. She tells you she's actually been on sertraline in the past, and it didn't really work for her, so she's more interested in talking to a therapist at the time. So you refer her to BHIP, which is in Roosevelt's behavioral health program. And you still have a lot to talk to her about, so you schedule a follow-up in a month. This brings me to my next slide, just to take a step back again. Now, individuals with chronic pain often have mental health comorbidities, and the two are often linked. So what the research has shown is that individuals with chronic pain have about a 7-fold increase in the risk of having clinically significant mood or anxiety symptoms. In other words, having chronic pain can be really hard and it can wear on your mental health. That said, there are also other studies, prospective studies, that suggest that premorbid psychological dysfunction is also a risk factor for the development of chronic pain conditions. So these two things sort of influence each other in both directions. This is really important actually for treatment implications as well, because there are studies that have shown things like mental health, negative affect, and distress can be associated with reduced benefits of treatment. So if you don't address the mental health first, a lot of the treatments for chronic pain might not be beneficial. And then another interesting study showed that things like anxiety, depression, emotional distress actually contribute more strongly to pain intensity, or strongly than pain intensity, to things like physical disability, healthcare costs, and mortality. So all reasons why addressing mental health is really, really important in our patients with chronic pain. Coming back to your case, you've now been seeing Betsy for 3 months. It's October of 2021. She's now been following with your clinic social worker, Jan, every week, and her physical therapist, Jeff. She loves spending time with both of them, but she often feels like in between appointments, she feels terrible. She feels like her chronic pain is really bothersome still, and it's making it hard for her to do her day-to-day tasks. She also has these pain flares and feels like her pain has been particularly flaring within the last few days. She locates this pain to her lower back, her hips, and her legs. She hasn't had any recent trauma or any strain on her back. She has no point tenderness of her spine, but endorses some tenderness of her paraspinal muscles bilaterally. Her creatinine is normal, and she has no history of GI bleeding or ulcers. So what would you like to discuss next?
And still a few answers trickling in here. Again, give about 10 more seconds for folks to share.
Lauren's wondering how old is she again? She's 82. Or did I say 84? Mid-80s.
All right, I'm going to go ahead and end the poll.
All right, so we've got things sort of coming up across the board, and it looks like the highest percentage is for acetaminophen, so Tylenol. So we'll see what we do. We'll give her some Tylenol or bring up some Tylenol. All right, you bring up Tylenol, and she says that she would like to actually avoid medication. She's told you this before. She didn't like the way her medications from her other provider made her feel. So you pivot and you bring up the idea of acupuncture, and she's intrigued about that. She asks you to place the referral. You also start to talk to her about keeping herself moving daily, and you give her some resources for making that happen. Which brings us to our next section, discussing the non-pharmacologic therapies for chronic pain. And I wanted to use this slide to emphasize that all of these guidelines for various conditions of chronic pain state that the first line or initial therapies should be non-pharmacologic if possible. And that's because while there still is a lot more research to be done on these therapies, they are generally low harm and they can actually impact pain and function. A lot of studies that have been done have shown. I want to bring specific attention to this 2017 ACP guideline for chronic low back pain that states clinicians should initially start with a broad range of different non-pharmacologic options. And they studied each of these, and they include things like exercise, therapy, mindfulness programs, acupuncture, yoga, among many, many others. And so taking a deeper dive into these non-medication treatments for chronic pain, starting off with your physical therapy and your therapeutic exercise. I think that a lot of us sort of are aware of physical therapy, and we often will provide physical therapy referrals to our patients. And this is maybe what we think physical therapy looks like. But I want to emphasize that there are actually a lot of other different exercise modalities that you can encourage your patients to do outside of physical therapy or in between physical therapy sessions. And those might be Tai Chi and yoga. Your patient might not be as good as this guy in the top left, but there are some really great programs for low impact exercising. Things like aquatic therapy for individuals who have a hard time being on land. This could be more low impact on their joints. And then even just home programs. So there are great things out there to encourage patients to do some of these things and these exercises at home, or even just encouraging your patient to do walking, daily walking or something like that could be beneficial. The goal of this is all to keep your patients moving. Yeah, I love it. I know, Joe, I spent a lot of time looking for these awesome photos on Google. And then I just want to point out really quickly here that another good resource that Dr. Gaster actually brought up last week could be your senior centers. There are a bunch of different senior centers that offer a lot of these in person, these exercise programs in person. And then maybe for younger patients or more tech savvy patients, there are a bunch of different resources online that are free or low cost to get themselves moving. The next thing that I want to cover here are the psychological therapies and the mind-body therapies. And we already talked about how mental health, addressing mental health can be really important, but things like cognitive behavioral therapy or pain psychology can even be impactful on patients who do not have underlying mental health comorbidities. So I want, we got the, I don't know if you guys can hear the earthquake drill in the background, but that's going on right now too. I wanted to point out the two differences here between cognitive behavioral therapy and mindfulness-based stress reduction. I think we all maybe are a little bit more familiar with CBT from medical school, but I just want to point out the differences. MSDR, or mindfulness-based stress reduction, is this very structured 8-week course plus a retreat, whereas with CBT, the timing varies. CBT has this big focus on education, so pain education, sort of like we talked about at the beginning, and then setting very concrete goals, whereas MSDR is sort of more fluid. It's about attention to your thoughts, emotions, sensations. They both have some form of relaxation techniques involved. And then I think the biggest difference here is CBT, they relies on this instruction and practice about changing your dysfunctional thoughts, whereas MSDR really focuses on sitting with your thoughts without trying to change them. So these two different types of therapies might be better for different patients, but both of them have pretty good evidence to show that they may be effective for treatment of chronic pain. And then the last modalities here that I want to point out are acupuncture and massage. There's moderate quality evidence for both acupuncture and massage that they're associated with lowering pain intensity and improving function. And sometimes even some studies have shown that even compared to medications that they may provide better relief than some medications. I will say that a lot of the data shows that these things might be better for short-term pain relief rather than long-term pain relief. So for treating things like pain flares. And then for both acupuncture and massage, cost may be an issue, although the Centers for Medicare and Medicaid actually finalized a decision, I think within the last 2 years, to cover acupuncture for Medicare patients, but other insurance may not cover these things. And then last thing I want to point out is the TENS unit or any sort of physical modality, any kind of simulator. There's actually not great data on this. The data is pretty poor quality and inconclusive on whether this is actually functional or useful for chronic pain. But they're generally low cost. You can see my screenshot of Amazon there. And so there are some guidelines that suggest that this may be something you offer, as it's probably low risk and may be helpful for certain patients. All right, so the take-home points here are that non-pharmacologic therapy is much, much more than physical therapy. And so be ready to provide those resources for your patients. Encourage them to move outside of their scheduled session. So outside of physical therapy, encourage them to be moving at home. Things like mind, body, or physical or psychological therapy might be beneficial adjuncts. Things like acupuncture and massage may aid in flares of pain. And then always, always multimodal, doing more than one thing is going to be better doing one thing alone. And I'll pause here for any more questions on that section.
I was curious if you saw any data in regards to kind of like socialization as opposed to like any physical therapy or kind of something that involves the body. And just the way you're painting the picture of this patient, it sounds like she's, she lost her sisters, we're in a pandemic, all of these things lead to social isolation. And I'm just curious, like, if you've come up with any studies that are like looking at prescribed, like, just hang out with friends.
No, well, that's
what
actually,
happens to your pain.
Yeah, that's a really great thing to bring up. There are actually a ton of things in the non-pharmacologic section that I didn't include here. And those are things like even like diet, weight loss, social support, like all of those things totally sort of play into pain. And I think a lot of the data on social support is often in these psychological studies about how people with social support tend to be less likely to have chronic pain. I don't know that there's been a lot of studies that sort of like reintegrate patients into society and see how that impacts as a treatment. But I think there's a lot of data to show that, yes, people who are lonely or have poor social support are more at risk. So getting them more involved in their community might be really beneficial. Awesome. And then there's some comments here from Lauren that patients who are at Evergreen might be able to get acupuncture, which is a great service. Greg Gardner from rheumatology used to write prescriptions for join a group and go walking together. And totally, like, I think that's a huge thing that we are trying to do with Betsy right now. Biofeedback therapy, yes, Mac, there is research on biofeedback therapy. And that sort of is in like maybe more the complementary and integrative medicine section, which I didn't get to in depth. But yes, there are studies on that. There are tons more studies on all of these things, which if you wanted to take deeper dives into it, I would encourage you to, but we only have so much time. Good question. Okay. All right, getting back to our case. All right, so getting back to Betsy, she is still following with social work, physical therapy, and acupuncture in February of 2022. At first, she felt the acupuncture was really helpful, but then the effect sort of wore off over time, and she wonders if it's still helping. She tells you that her pain is still impacting her sleeping. She's having trouble sleeping, and her PHQ-9 is a little bit better at 19, but still pretty high. And then you're sort of thinking, and you've been, visiting with Betsy every month for about 6 months now, and you feel like your therapeutic relationship is getting better. So you think maybe it's time to revisit this conversation about medication, which leads to my next poll. What would you like to discuss with Betsy next if your next discussion is going to be about medication?
I still see some answers trickling in, so give another 10 seconds or so.
Will, you're still unmuted, so I can hear you laughing, which I love, but
All right, I'm gonna go ahead and end the poll here. The great laugh.
It's a fantastic laugh. All right, A and C, which was revisit the discussion about duloxetine and prescribe acetaminophen to be used as needed. And we will come back to this with what we did after we learned a little bit about the pharmacologic principles of medications for chronic pain. So a couple of principles here, I'll go through these briefly. First principle is to target your pharmacologic therapy to the type of pain the patient has. And I will come back to this in the next slide. The second point here is, again, to educate your patient at every step of the way, including when you're prescribing them medication. Part of that education should include these next 2 points. You should always prescribe prescribe one medication at a time. A lot of the guidelines really emphasize this. And the purpose of prescribing one medication at a time and really being patient with this is to make sure that you can really identify what medications work for a patient and to identify what side effects if a patient has side effects or which medication a side effect might be from. The next point that you're going to emphasize to your patient is that you're going to titrate these medications with patients. A lot of the guidelines, similar to with antidepressants, emphasize that whenever you start a medication for chronic pain, the medication you should assess the medication after about 4 to 8 weeks of therapy to really give it time to work before you think about changing anything about the medication. And then again, coming back to this emphasis that multimodal therapy is going to be better. So more medication or, different medications targeting different things might be better than one medication alone. So inherent in this prescribing is going to be this discussion of different types of pain. And I think this is maybe the most challenging slide in the whole deck to sort of understand. But when you're treating chronic pain, you should take into account these three types. So the first type of pain that I want to point out is called nociceptive pain. And this is damage to non-neural tissue and is due to the activation of nociceptors. An example of this might be your osteoarthritis, something that causes inflammation at a specific site that causes activation of peripheral nociceptors. The second type of pain is neuropathic pain. I think we all have an idea of what neuropathic pain, and this is caused by a lesion or disease of the nervous system. An example of this might be something like diabetic neuropathy or herpetic neuralgia. And then there's this last type of pain, which is called nociplastic pain. And the definition of nociplastic pain is that it arises from altered nociception despite no clear evidence of tissue damage causing the activation of peripheral nociceptors or a disease of the nervous system. And so a disease in this class might be something like fibromyalgia, where there's not really clear damage in a specific part of the patient's body, but the patient is still experiencing pain. Inherent in this nociplastic pain is also these concepts of things like sensitization or increased responsiveness in the patient's brain to the same input as before, or hyperalgesia, which is this increased sense of pain from the same stimulus. And I want to point out here that these different types of pain don't just exist alone, and that there's often a lot of overlap in our patients with chronic pain. And I think a good example of that is patients with chronic back pain. Some degenerative joint disease might initially be in this nociceptive pain category, but from research, we know that over time, patients with chronic back pain actually display a lot of nociplastic pain characteristics as well. And so a patient's type of pain may change over time. A lot of the guidelines emphasize if a type of medication you're prescribing for a specific type of pain is not working, take a step back and reevaluate if this is truly the only type of pain the patient is experiencing. And we can come back if people have questions about this. I want to take a deeper dive into some of these medications for chronic pain, and I'll talk first about NSAIDs and acetaminophen. This is what a lot of the slides are going to look like for your medications. And I know we've all learned the pharmacology of these things and the side effects of these medications. So I think it would be more interesting probably to point out where in the pathway of pain these work. So I'll bring your attention to this picture on the right-hand side of the slide. This is a graphic from UpToDate. You can see the red arrows. Those are the ascending pain pathway, and medications that work here inhibit the ascending pain transmission. In other words, they'll stop the pain transmission before it comes to the brain, or they'll dampen the pain transmission. Whereas the blue side is the descending pathway, and medications here are often produced in the brain, and then they facilitate sort of descending pain modulation. So travel down more so to the peripheral nervous system and modulate the pain signal. And so NSAIDs specifically will work sort of in this ascending pain. They'll target inflammation in the periphery. And so because of that, they tend to be most effective for nociceptive pain. They are the first line therapy for nociceptive pain. I know you guys all know the side effects of NSAIDs and know that we may have challenges prescribing them in certain populations. And that's why topical NSAIDs may be helpful for some patients with nociceptive pain, particularly if they have only one or a couple of places involved. I'm not going to belabor NSAIDs, but I do want to point out here that while we're talking about topical things, this was something that was really interesting to me. Topical lidocaine and capsaicin are actually more well supported for neuropathic pain than they are for nociceptive pain, even though we often, I think, give them for patients with MSK pain. So interesting thing there. All right, going next to acetaminophen. So something super interesting about acetaminophen that I learned is that we still really don't know how acetaminophen works and where it's targeting our brains or our bodies in the pain pathway to produce analgesia. There are a bunch of different theories, and I think maybe the most well-supported one is that it does impact the cyclooxygenase enzyme production in the brain, so also focusing on this ascending pathway. You can see that there are a lot of question marks on this slide here because there's, in studying acetaminophen, I know we give it all the time because it's got an okay side effect profile. There's actually pretty low efficacy for its impact in chronic pain. And it's not considered first line for things like chronic OA and chronic low back pain due to this lack of efficacy. So I wanted to bring your attention to that. And then I'll bring your attention to the fact that I know we often think about this max daily dose as being 4 grams. However, it may actually be lower for longer term use, more like 2 to 3 grams might be safer. The next medication class, and Jess, Reed, I'll get to your question maybe. Oh, okay. Have you read anything about long-term safety profile NSAIDs? Yeah, I generally tell people to limit around the clock use for 2 weeks max. Yeah, I think that's a really good question. That's often what I tell people as well is about 2 weeks. And I didn't read anything more sort of into what longer courses might look like. And I think it's probably going to be really patient dependent, but that's a good question, maybe something to look into. The next section here is on antidepressants, and I'll talk about 2 classes that are common for chronic pain use. The first one is tricyclics, and tricyclics tend to work on the descending pain pathway and modulating pain signals from above, tend to be prescribed for more neuropathic pain and nociplastic pain. And then I'll say that tricyclic antidepressants are used for a variety of different pain conditions like migraine prevention, post-herpetic neuralgia, diabetic neuropathy, et cetera. But they're not actually approved for chronic pain management, FDA approved for chronic pain management in these conditions, even though they are often used. And then I think the other interesting point that came up with tricyclics that I found was that even though a lot of the studies in these disorders were using amitriptyline as the TCA of choice, nortriptyline is actually less sedating and has fewer anticholinergic side effects. So many guidelines recommend this one as a first treatment option if you are going to use a tricyclic. The next class here are your SNRIs, and these also work on the descending pain pathway. And this is maybe sort of the broadest class of medications that really impact various different types of pain. So neuropathic pain, nociplastic pain, but maybe also chronic MSK pain. You can see at the bottom there, particularly duloxetine is FDA approved for fibromyalgia, and there's only 3 that are. It's also approved for diabetic neuropathy, chronic low back pain, and chronic OA. And then the other interesting thing that I found when researching SNRIs is that milnacipran, which I had never heard of, is also approved for fibromyalgia. And this is maybe an even more potent norepinephrine reuptake inhibitor, so may work even better than duloxetine. And then I'll mention venlafaxine, which is the other common SNRI. Venlafaxine tends to work more like an SSRI at lower doses. And so if you want to use it for neuropathic pain, you're going to want to use higher doses. The next class of medications here that most people know about are your gabapentinoids. So the gabapentinoids also work on the descending pain pathway, and particularly gabapentin is used really specifically for neuropathic pain. It's been most well studied with herpetic neuralgia and diabetic neuropathy. And then I think I want to point out here that the effective daily dose for gabapentin's treatment of pain is actually quite high. So in order to treat pain, studies have shown that you really have to get to a dose of 1,200 to 2,400 milligrams daily. So your patients who are on, 300 milligrams of gabapentin, it may work, but it's more likely that they probably aren't having much effect from that gabapentin at such a low dose. And then John pointed out in the chat, venlafaxine has a high dose related risk for hypertension. So higher doses may be associated with that. And so it's a really good thing to be thinking about in terms of side effects. And then pregabalin, which is our sort of newer gabapentinoid on the market, works very similar to gabapentin, but I think the difference here and the reason why it actually might be more effective than gabapentin is this effective daily dose. So you need a lower dose of pregabalin, only 150 to 300 milligrams, which are on the lower doses of it anyways, to really impact pain. And so that's why it might work a little bit better. And then in addition to the things that I mentioned that gabapentin is useful for, pregabalin is also pre-approved or approved for fibromyalgia treatment. It's the last of the three. And then it's also approved for individuals with spinal cord injuries with neuropathic pain. You guys probably all know you have to look at the PDMP when you prescribe pregabalin. It's because it is a controlled substance. And the reason why that is because it can be psychoactive at higher doses and so has some abuse potential. The next class is our muscle relaxants. And what I'll say about muscle relaxants is that they have a very diverse effect, and they're really not a class of medication. None of them actually act on the muscle itself. I think ones that I've seen used often are something like methocarbamol actually has no indication in the use of chronic pain at all. The two that I'll point out are cyclobenzaprine and tizanidine, which may have some indications for chronic pain use. Cyclobenzaprine actually works similar to a TCA, and then tizanidine is an alpha-2 agonist. They likely work on the descending pathway as well. And what I'll say about how they work is that some studies think that they sort of impact pain due to their sedation rather than due to analgesia. And then I'll point out that cyclobenzaprine is one of the medications that's also approved for fibromyalgia, but only for short-term use. So that might be something that you prescribe to someone in fibromyalgia with flares. And then last but not least, as you can see, this talk is not about opioids, and we're going to have a lot more talks, I know, at Academic Cafe about opioid use disorder. But opioids are more targeted for nociceptive pain. They target this ascending pain pathway. And routinely, they should not be used in chronic pain. And I think a lot of folks know this. They should be reserved for patients with debilitating chronic pain, despite trying all of these other multimodal therapies, non-pharmacologic and pharmacologic. If you're going to prescribe opioids, you want to start with immediate release at the lowest dose for the shortest amount of time possible. And then if you have patients who come to you on opioids, you could consider tapering, but if you're going to taper, make sure you do it quite slowly. And that's if their opioids are not improving their pain or function. All right, any questions before we get back into the case and conclude here?
I'm just gonna jump in for a sec here, Gina, and say that our interns are going over to intern report at 10:45. So maybe, is this a good time for them to pop over there and wrap up with the seniors, or?
If they want to, there are 3 slides left.
Okay, got it. Okay, great. I'll hold off on putting the link in, and we'll let you wrap up.
Yeah, cool. But if they want to take a break, feel free to pop off now. This is just the case resolution. So going back to our patient, what did we do? We didn't prescribe her 2 medications just to be really safe about what we were identifying so we could identify what might work for her. But we did start her on duloxetine in February. We then increased her duloxetine to 60 milligrams when she came back in April. We tried to start her on some gabapentin, 300 milligrams at night in July. And then we promptly discontinued gabapentin because she was having some side effects to it shortly after that. And so looking back on this case, this is a real patient from my clinic. I have seen her 14 of my 16 months of residency. And I think before sort of understanding this talk, I would have looked back on this and said, gosh, I have only prescribed this woman duloxetine and done nothing else. But in reality, we've done a lot more. She's continued her physical therapy with Jeff. She's following with social work and getting some sort of mental health treatment there. She's doing daily walks. We tried acupuncture, and we know this might be something we can go back to for some flares. We have diagnosed her with fibromyalgia, which was actually something that was helpful for her to sort of understand her disease process better. As Will was saying, we have connected her to the Greenwood Senior Center and are trying to get her more engaged in the community. And then we have built up our therapeutic relationship a whole lot over those 14 appointments. And then what do we still have left to do? We're still working on getting her with formal pain psychiatry or psychology, still readdressing a lot of the medications. We're trying to get her to do her walks in athletic shoes because she is currently doing all of her walks in her little heels. We're trying to get her more engaged in the community. We're working on, maybe I'll start doing some pain measurements with her, and then we'll be working on spacing our appointments out. So overall takeaways are education and expectations are often the cornerstone of chronic pain treatment. So engage your patient early and often. Address their mental health early. Emphasize to them that pain is complex, and so a multimodal approach is going to be the best. Start with and encourage non-pharmacological therapy throughout. Be very intentional about your medications you prescribe. Prescribe them one at a time and give them time to work. And then a therapeutic relationship is key to all of this. And if you guys have any questions, I'll take them now. And feel free, all of the resources that I talked about are actually in this dot phrase here. So you can steal this dot phrase, .abs chronic pain from me as well, which might be helpful, and you can make it your own. Yeah, HOCAS would be best.
Yep, HOCAS, shoe inserts. I'm seeing the GOAT, or greatest of all time, primary care right here. I'm going to go ahead and throw in the link for intern core conference. But maybe if other folks have questions, you can hang tight here for a little bit, Gina, and answer anything that comes up.
Sounds good.
I didn't know about this dot phrase. Is that one that's existed?
Oh no, this is my own dot phrase. So I put a lot of these resources into here. So feel free to steal it and
that's
paint
amazing,
it, make it your own. Yeah.
Thank you for putting that together. I'm definitely
for sure
going to borrow that.
Yes, I survived the earthquake over here, John.
And a lot of comments in the chat about this was really helpful, amazing. Thank you so much. Great talk.
Sweet.
I agree with all of the above.
Gina, can I ask, since you did the research on medications, where do you put tramadol in the whole schema?
Yeah, great question. And I originally had tramadol in there, but pressed for time, so took it out. Tramadol sort of falls into this opioid category of like, probably shouldn't use for long-term chronic pain, but while also recognizing that there's not as many sort of treatments for this nociceptive, like truly nociceptive pain. And so that's sort of like, before you get to other kinds of opioids, tramadol sort of fits right there. Like maybe if you've exhausted all these other options, tramadol would come before the other opioids, but still not really super recommended for long-term chronic pain, if you can avoid. Sweet.
That's great.
All right.
Well, thank you. Thank you so much, Gina. Thank you, Lily, both of you for amazing presentations today. I learned a ton. I think the rest of this time you can use for whatever you need to do this morning. I think Kelly sent out an email about some learning modules that are due coming up here soon. And sometimes folks always have evaluations hanging out. So feel free to take this time to do that. I'll hang out here for a little bit longer if folks have any questions about anything or just want to check in.